This conference will now be recorded.
So today's talk is article from July 2020, that is ocular manifestations in pregnancy and labor from the innocuous to the sight-threatening ocular problems in pregnancy. Okay, so this talk basically discusses all minor to major changes that can occur during pregnancy or diseases. Either maybe it is a physiological or pathological, and in great detail discuss about the diabetic retinopathy, which is the most common thing, which is the pathological thing which can occur in pregnancy. So coming to this discussion today. So first is several ocular changes. This can occur during pregnancy, but mostly they are transient and rarely they cause problem. They affect different structures of the eye and can lead to different type of visual symptoms. So coming to the differential diagnosis of different symptoms. So if the patient complains of unilateral blurred vision, it can be due to refractive changes, central serous chorioretinopathy, and diabetic eye disease. Unilateral blurred vision. Okay, so refractory changes, you have to do refraction. For central serous retinopathy, you have to do the OCT scan, that is the major investigation, and Amsler's grid. For diabetic eye disease, again it is a fundoscopy, retinal examination, blood sugar, and HbA1c. Then bilateral blood vision without headache. Bilateral visual disturbances without headache. Differential diagnosis for this will be either refractive changes or cephalgic migraine. What do you mean by cephalgic migraine? So migraine without headache. It is known as migraine without headache. Okay. Then diabetic eye disease, pituitary disorders, preeclampsia, eclampsia. In that, more important is pituitary disorders. You have to remember that. And if you suspect pituitary disorder, you have to do the neurology referral within 24 hours because this is an emergency. Okay. Other things which are emergency again is preeclampsia, eclampsia. Other things you can manage with the routine referral. Then bilateral blurred vision with headache. So with headache, differential diagnosis is migraine, pituitary disorder, and preeclampsia, eclampsia. Again, as I told you, pituitary disorder, this can be a emergency because it can, the major differential diagnosis for a pituitary disorder is pituitary apoplexy, which we are going to discuss later. So it is an emergency condition. So coming through the ocular condition one by one. So first coming to the ocular adnexa. Ocular adnexa, in that the first benign or non-troubling condition is melasma or chloasma. It is also known as mask of pregnancy. It is the facial skin hypopigmentation and the distribution is malar pattern. But sometimes it can also affect the eyelids. This melasma or chloasma, this can also affect the eyelids. It usually occurs in second half of pregnancy in up to 75% of women. Okay. The cause is increase in the circulating melanocyte stimulating hormone. Who's any doubt? Someone's mic is on. We are 1 minute. Please mute your mic, Kavya. Yeah, okay. Yes. So this cause of melasma is increased levels of circulating melanocyte stimulating hormone, estrogen and progesterone. It is usually self-limiting and usually regressed in 90% of women within 1 year of postpartum. Then ptosis. Ptosis is definition of ptosis is drooping of eyelid. In pregnancy, it is usually occur due to hormonal changes or fluid retention within the levator muscle aponeurosis. Usually during pregnancy, it is mild and often unilateral. So mild ptosis without any associated symptoms, it doesn't require any treatment and it usually resolves following delivery. So mild ptosis without any associated symptoms or pupillary abnormalities. Now, which ptosis requires evaluation? So when ptosis is associated with smaller pupil, so smaller size of pupil along with ptosis is suggestive of Horner syndrome and it requires further investigation by neuroimaging of the oculosympathetic pathway. Also, you have to see for the chest imaging where you have to see for any sympathetic chain problems. Okay. Also, ptosis which is associated with diplopia with or without dilated pupil, it's suggestive of oculomotor nerve palsy. So whenever this ptosis is associated with symptoms like either small pupil or diplopia, then it requires the further neurological evaluation. And when the ptosis is associated with diplopia, it is usually third nerve palsy and requires urgent ophthalmology referral. Now coming to the cornea and refractive changes during pregnancy. So during pregnancy, fluid retention in cornea occurs and it is responsible for increase in corneal thickness, and it increases up to 30%. So with this retention of water in the crystalline lens also, so one is increase in the corneal thickness and water retention in lens. It is responsible for refractive errors, okay, or refractory changes that can occur during pregnancy. So 14% pregnant women experience increased myopia. Okay, so they report blurred vision usually for distance. So here the diagnosis by optometrist. So referral to the optometrist should be done, and refractive error should be assessed. But usually it is advisable to avoid prescribing new glasses during pregnancy unless it is required, because it keeps on changing. So usually avoid prescribing new glasses during pregnancy because these refractive errors are more common in pregnancy because of this increased corneal thickness. Another thing, when the pregnant woman who use the contact lenses, usually these rigid lenses, they experience this tight lens syndrome. What do you mean by tight lens syndrome? Because of this corneal thickness, increased corneal thickness, the removal of this rigid lens becomes difficult, which leads to pain and redness. Also, again, this compromised cornea, because of this tight size of this lens, it may swell even further, and which will only exacerbate the problem. So it is a tight lens syndrome because of increased corneal length, thickness. Laser refractory surgery is contraindicated during pregnancy because there will be change in refraction. So laser surgery for refraction is contraindicated during pregnancy. So it should be delayed at least 12 months after the delivery. Any refractory surgery, it should be delayed at least 12 months after delivery. Then another condition which is known as Krukenberg spindles. So what do you mean by Krukenberg spindle is pigmentation of posterior surface of cornea. It can be seen in first and second trimester of pregnancy in 3% of women, but in pregnancy, it is not associated with increase in intraocular pressure, and it spontaneously disappears in third trimester of postpartum. So when these Krukenberg spindles, they occur in non-pregnant women, they are associated with increased intraocular pressure. But when these Krukenberg spindles, they occurs in pregnancy, they are not associated with increased IOL or intraocular pressure, IOP. Now, changes in tear film and ocular surface. So usually there will be a dry eye because there will be tear film disturbances that can occur during pregnancy because of hormonal changes. It causes dry eye symptoms. So usually the pregnant woman, they present with foreign body or gritty sensation, which transiently improves with blinking. So for these ocular lubricants, which are available over the counter, they can be used. Now, changes in eye pressure during pregnancy. So remember, pregnancy leads to fall in intraocular pressure. There will be slight fall in intraocular pressure by 2 to 3 millimeters of mercury because it is change in the progesterone level. It causes reduction in episcleral venous pressure. So the resistance to aqueous flow will be reduced. That will lead to slight reduction in intraocular pressure, and this intraocular pressure reduction is by 2 to 3 millimeters of mercury. So the women who have already pre-existing glaucoma, they may have modest or slight improvement in their glaucoma symptoms. Okay, and usually this eye pressure changes return to the normal level 2 to 3 months after the delivery. Now, women who are regular topical treatment for this glaucoma or intraocular pressure, they should seek advice from an ophthalmologist regarding safety of these eye drops during pregnancy and breastfeeding. Usually, topical medicine, for topical drops, there is little evidence of harm because systemic absorption will be low. But systemic medications, they should be used with the proper advice. So to avoid this absorption of these topical medications, there are two things that are advised. One is this is known as punctal occlusion, and another thing is Where this punctal occlusion may not be sufficient, there will be temporary punctal plugs will be there. They can be inserted by ophthalmologists. So this is basically when the harmful to the pregnancy eye drops are used. So to avoid the systemic absorption of this topical eye drops, these are the two techniques. One is punctal occlusions or punctal plugs. So what do you mean by punctal occlusion? So it is, you have to apply both index fingers in the corners of the eye for about 2 minutes. So it blocks the lacrimal drainage of these topical drops and its passage into the systemic circulation. So it reduces the risk of systemic side effects of this topical medication. It is recommended for all pregnant and breastfeeding women who may use these eye drops associated with potential risk. So these are the two things, that is punctal occlusions and punctal plugs. Now, so till now we were seeing about the anterior segment. So we saw about the cornea, lens, and this thing. Now coming to the posterior segment of the eye. So unlike anterior segment manifestation, so till now you have seen that anterior segment manifestation, these are usually temporary and they are more in the view of physiological things which revert back to the normal after the pregnancy. While posterior segment changes, they are usually pathological and they require ophthalmology referral. Most common of the posterior segment disease is progression of diabetic eye disease. Other posterior segment conditions, they are uncommon in pregnancy. So if you are suspecting any posterior segment disease, detailed examination of this posterior segment is required. And for this, so usually it is a retinoscopy or fundoscopy. So for that, it requires pupillary dilatation. Now for pupillary dilatation, we usually use this topical medicines. So for this pupillary dilatation, phenylephrine is best avoided because of its systemic delivery and it is associated with birth defects and fetal cardiovascular defects. So for this, phenylephrine should be avoided. But the drugs which can use for pupillary dilatation in pregnancy are tropicamide and cyclopentolate. So tropicamide and cyclopentolate, these are preferred for pupillary dilatation in pregnancy. Now coming to the diabetic eye disease. So pregnancy, it is an independent risk factor for progression of diabetic eye disease. And the woman who have this pre-existing diabetes, now it is a routinely asked question. So type 1 diabetes or pre-existing type 2 diabetes, the retinoscopy should be done at the first antenatal appointment. Okay, so immediately after booking, first a retinoscopy or retinal examination should be done. If it is normal, then it is repeated at 28 weeks of gestation, and if it is abnormal, another assessment should be done at 16 to 20 weeks of gestation. It is also routinely asked question, remember well. So for normal, first retinoscopy should be done immediately after the booking. If it is normal, repeat at 28 weeks. If it is abnormal, repeat at 16 to 20 weeks. Now for high risk women who have already having changes of either non-proliferative or so severe non-proliferative or proliferative diabetic retinopathy, more frequent examinations are recommended depending upon the severity and likelihood of progression. But remember, presence of diabetic retinopathy is not a contraindication for vaginal delivery regardless of its stage. So previously it was thought to be known that progressive or proliferative diabetic retinopathy is a contraindication for vaginal delivery. It is not. So even if the patient is having proliferative also, yeah, we will be coming to that strict sugar control. Okay. So even if the diabetic retinopathy is proliferative or severe, the vaginal delivery is not contraindicated. Okay. Another thing, the diabetic retinopathy, it is classified into non-proliferative and proliferative. Non-proliferative, it is further classified into mild, moderate, and severe. Okay. So the how it differentiates from proliferative in non-proliferative. So in proliferative diabetic retinopathy, there will be neovascularization. So it develops the normal new blood vessels. Okay. Previous GDM is not required. Okay. See. So the risk of developing advanced retinopathy as a result of gestational diabetes is only low. So if there are any concern, then only she should be referred for ophthalmology. But routine screening for retinopathy is not advised for previous GDM also, even for previous GDM. Okay. Only for pre-existing diabetes it is required. So For non-proliferative diabetic retinopathy, you can see here. So at first screening visit, this patient, she was a 34 years patient who is having type 1 diabetes mellitus. So in the first visit, she is having this mild or moderate non-proliferative retinopathy. You can see here small hemorrhages, okay, with this white arrow. Now, when she reviewed at again 7 months, that is 28 weeks of gestation, there was a progression of this non-proliferative diabetic retinopathy to severe state, okay. So there was development of new hemorrhages and also yellowish exudates. So these yellowish exudates, they are shown by black dots. White new hemorrhage, you can see there were only mild hemorrhages previously. Those are progressed to the more dense hemorrhages. So there will be progression. So what is the risk of progression for this NPDR? So for non-proliferative diabetic, little or no diabetic retinopathy previously, they are unlikely to have significant progression. And mild progression occurs only in 10 to 20% of patients. So previous no history of diabetic retinopathy or little diabetic, only mild diabetic retinopathy, risk of progression is around 10 to 20%. But those who have moderate to severe non-proliferative retinopathy before pregnancy, progression occurs up to 54.8% of cases. And development of proliferative retinopathy occurs in 6.3% of those with mild non-proliferative and 29% of those with moderate to severe non-proliferative. So progression can be mild to moderate or moderate to severe, or from non-proliferative to proliferative. So these are the different percentages for this. So for treatment of diabetic retinopathy, it is the multidisciplinary collaboration is required, which should involve endocrinologist, obstetrician, ophthalmologist, okay, for optimal control. Now, what are the risk factors for development of this diabetic retinopathy in pregnancy or progression is duration of diabetes, high HbA1c levels, and advanced level of diabetic eye disease. So these are the additional risk factors apart from pregnancy. Again, it is known that rapid improvement, so rapid control in glucose, it leads to the progression of retinopathy. But again, rapid control of glucose is advised for the good pregnancy outcomes. So now it should be balanced with multidisciplinary team input. Okay. So how rapidly the blood sugar should be controlled in this diabetic retinopathy woman. So it should be managed with the multidisciplinary team management. Women with moderate to severe NPDR who are diagnosed during pregnancy, they should have 6 months of ophthalmic follow-up after delivery. So NPDR, it doesn't require any treatment during pregnancy. Remember well, only it requires is the sugar control for non-proliferative diabetic retinopathy. While proliferative diabetic retinopathy, it requires treatment during pregnancy. Remember well, non-proliferative doesn't require treatment. It requires only control to prevent progression. So this is proliferative diabetic retinopathy. Here you can see the proliferative changes. That means development of new blood vessels here in the macula or optic nerve head. Here you can see this is optic nerve head. There is development of new blood vessels also in the periphery of the retina. Okay. So proliferative diabetic retinopathy, it should be treated by ophthalmologist. So now what are the treatment options available for this PDR or proliferative diabetic retinopathy? So retinal laser photocoagulation, it can be performed to induce regression of new vessels. It is safe during pregnancy. Now more severe cases of proliferative or PDR, there will be, so it can lead to bleeding, which will lead to vitreous hemorrhage. Vitreous hemorrhages, they will usually clear spontaneously, and vitrectomy surgery, it should be delayed until after delivery. But sometimes urgent vitrectomy is indicated if there is abnormal fibrovascular tissue, it will contract, which will cause a traction retinal detachment that affects the central vision. So urgent vitrectomy is only indicated in case of traction retinal detachment, which is affecting the central vision. Otherwise, vitreal surgery is delayed up to the delivery. So which is the treatment which is recommended for PDR is laser treatment. Then in PDR or proliferative diabetic retinopathy, it offers diabetic maculopathy also, or diabetic macular edema. It can be also treated with laser photocoagulation, but only if there is focal leak away from the center of macula. Now, when the edema involves center of the macula, so when this macular edema, it involves center of the macula and is threatening the vision, it should be treated by injections, intravitreal injections of anti-VEGF, antivascular endothelial growth factor. Now, this antivascular endothelial growth factor or anti-VEGF drugs, these have potential risk of adverse effect on the developing vasculature of fetus. So, they are best avoided. So, anti-VEGF should be avoided in pregnancy, and who have received this anti-VEGF, they should wait for 3 months before conceiving because it has an adverse effect on the vasculature of the fetus. Remember well. So this anti-VEGF, they should be avoided in pregnancy. Now, the woman in pregnancy who develop significant macular edema and who are at risk of irreversible vision loss, here benefits and risks, they should be discussed. Okay, so counseling should be done regarding the benefit versus risk of this anti-VEGF drugs. And if it is recommended that anti-VEGF should be used to avoid irreversible vision loss, then ranibizumab, that is the drug which is preferred to bevacizumab or aflibercept. Okay, so ranibizumab is the drug of choice for this pregnancy, proliferative diabetic retinopathy or central macular edema. Alternatively, you can use intravitreal steroid implant. It can be considered because it doesn't cause systemic side effects. So for PDR, what are the treatment option available is either laser photocoagulation. Second thing is you can use this anti-VEGF drugs only when the benefits is more than the risk. Okay, so you have to weigh this risk versus benefit, and when the benefits are outweighing this risk, that means if it is there is a risk of irreversible vision loss, then only you should use, and in that ranibizumab is preferred drug. Now coming to the PIH or pregnancy related hypertension, so it occurs in around 11% of pregnancy.
Sorry, ma'am.
Yes.
Can I ask?
Yes. Yeah. Hello. Hello. Who was?
Hello.
Yes, Shilpi.
It's me.
Yes,
Yeah.
Shilpi, go on.
I just wondering these ranibizumab or bevacizumab are the type of anti-VEGF then?
Yes. These three are anti-VEGF. Ranibizumab,
Yeah.
bevacizumab, and aflibercept. These are anti-VEGFs. Okay.
Okay. Okay. Thank you.
And of these three, this one is the preferred one, ranibizumab. Okay. Yeah. Now coming to the PIH or pregnancy-related hypertension, it occurs in 11% of pregnancy. Ocular changes or fundus changes occurs. These are directly proportional to the severity of hypertension. And here diastolic blood pressure correlates well to the ophthalmological changes. Okay, than systolic blood pressure. So what are the fundal changes that can occur is retinal arterial attenuation or superficial retinal hemorrhages or cotton wool spots. So these cotton wool spots, these are yellowish white fluffy spot in the superficial retina, which are usually caused by accumulation of neuronal debris because of axonal loss. Okay, so if this cotton wool spots or retinal hemorrhage develops in the central retina, then there will be blood patch in the field of vision. So in severe preeclampsia or eclampsia, also this occurs that CME, which we call it as CME or cystoid macular edema, serous retinal detachment can occur, optic disc swelling can occur. This can affect vision, and this is indication for immediate ophthalmic referral in case of PIH. Double vision, scotoma, and photopsia, these are also symptoms which can be reported. So whenever a PIH patient, she complains of visual disturbances, ophthalmic referral is urgently required. So here you can see this is a severe hypertensive retinopathy. So here you can see these are the dark blue arrow is the vein and this is the artery. So you can see there is significant arteriolar narrowing. Okay, in case of severe severe hypertensive retinopathy, also there is optic disc swelling. Okay, so there will be arteriolar dimensions. So this arteriolar narrowing will be there. Normal AB ratio is 3 is to 4. You can see, but here there is significant narrowing is there. Some superficial hemorrhage are there. Some cotton wool spots are also there. You can see these fluffy spots. Okay. Now, another form of retinopathy which can occur in pregnancy is central serous retinopathy. What do you mean by it? It is a localized serous detachment of neurosensory retina at the macula. So it is a macular retinopathy because of leakage from choriocapillaries from one or more hyperpermeable retinal pigment epithelium. It usually occurs in childbearing ages or reproductive age. Incidence is 4 in 17,000 in case of uneventful pregnancy or 0.008%. The cause is unknown, but it can be precipitated in pregnancy by multiple factors. So multiple factors are responsible for this CSCR, that is central serous chorioretinopathy. So the factors which are responsible for is high cortisol levels, increased vascular permeability, decreased colloidal osmotic pressure, and changes in the prostaglandin level. Also parenteral steroid intake. So the symptoms of the CSCR are micropsia. That means the images, they appear smaller. Metamorphosia, that means distortion of images or blurred vision. It is usually occurs during the trimester. Diagnosis is by Amsler grid. Okay. So, or you can ask the woman to fix on a central dot and to draw or describe any anomalies on the grid. So here you can see this Amsler grid. Here the patient, this grid is composed of 10 centimeters square with a central black dot. So patient is asked to concentrate on the central dot, and then patient has to report whether she is feeling or she is having any visual disturbances. Okay. So that means any discontinuity or thinking in the line or distortion. Also, another thing, another diagnostic test for this CSCR is the optical coherence tomography, which is known as OCT scan. So it reveals the elevation of neurosensory retina at the macula. So this OCT is the key for diagnosis of this CSCR and for monitoring the condition. It is a non-invasive imaging which renders high resolution cross-sectional image of the retina, and it takes only seconds. So this is this OCT scan. Okay. So here you can see this is the retinal detachment. You can see here. Okay. And this is the OCT scan. Here you can see it is the detachment of the central retina here. So the CSCR, it does not require treatment and it resolves towards the end of pregnancy or usually few weeks or months postpartum. But it may recur in subsequent pregnancy or at any point in woman's lifetime. So it is prone for recurrence. Other ocular disorders, these are neuro-ophthalmic disorders or pituitary disorders. So pituitary disorders, so pituitary is known for physiologic enlargement during the pregnancy because of this prolactin hyperprolactinemia or increased lactotrophs. Also pre-existing adenomas, they can increase in size, and the proximity of this adenomas to the optic chiasma, they can compromise the visual field either bilaterally or unilaterally. So here optic nerve function should be done and visual field testing should be done. So bitemporal visual field defect is the classic finding for any pre-existing adenomas, but other field defects can also be seen. So if you suspect any neurological abnormality, then neuroimaging and neurology input should be taken. Also visual fields, along with visual fields, optic nerve and macular ganglion OCT scan, they should be performed. Okay. Also repeated visual fields and OCT scans, they are required for the monitoring. Again, for this neuro-ophthalmic disorders, always help to so take a detailed history. You should always exclude any migraine because it may cause the headaches with or without visual disturbances. And frequency of migraine, it can change anytime during the pregnancy. So this is the most common cause that you should rule out first for any visual disturbances along with headache. Also, sometimes there will be a sudden onset of thunderclap headache or visual disturbances. So thunderclap headache plus visual disturbances, this can be a differential diagnosis for pituitary apoplexy. What do you mean by pituitary apoplexy? There will be enlargement of pituitary gland, which may be physiological in case of pregnancy. It causes increase in the intracapsular pressure within the confined sella turcica. Okay, so the pituitary gland cavity is very limited. So if there is any increase in the gland size, it increases the intracapsular pressure, which will cause ischemia and thrombosis, and finally it leads to hemorrhage also. So this pituitary apoplexy, it is a medical emergency because there will be impaired pituitary function and it requires hormonal replacements. Then another thing which is usually associated with visual disturbances is idiopathic intracranial hypertension. So it is usually common in women of childbearing age, and it has a strong association with obesity. So weight gain, it lead to its onset and exacerbation. The main features of this idiopathic intracranial hypertension is raised intracranial pressure without localizing signs. Remember, it is without localizing signs. So the sign symptoms are headache, nausea, vomiting, transient visual obscurations, and pulsatile tinnitus. Usually the symptoms are worsened by Valsalva maneuver or lying flat. Papilloedema, it is usually seen because of swelling of optic nerve head because of increased ICT. And sometimes unilateral or bilateral 6-nerve palsy is possible. This is known as false localizing sign. Okay, because of the pressure effect, there can be either unilateral or bilateral 6-nerve palsies also can be there. So for differential diagnosis of this idiopathic intracranial hypertension, you have to always rule out any venous sinus thrombosis or space occupying lesion. So for that, you have to do either magnetic resonance venogram or MRV or CT venogram, okay, for to rule out any thrombosis. Also, MRI or CT scan is required to rule out any specified space occupying lesion. So for this IIH, ophthalmology input is required to assess the optic nerve function and appearance. Also, the OCT scanning and ophthalmoscopic assessment of optic nerve head. First line treatment is weight reduction. Okay, so it is a multidisciplinary team management with weight reduction is the basic thing which is required. Drugs which are used for IIH is acetazolamide. So it is the first line medical agent, but usually it should be avoided in pregnancy. Okay, usually at least in first trimester it is avoided unless there is clear risk of visual loss. Okay, and if used, there should be always the risk and benefit should be explained to the patient. So the main modality of treatment for this IIH is targeted weight loss. Then another DD for this IIH is severe preeclampsia. So again, you have to rule out it by using the high blood pressure measurements, proteinuria, and any other systemic involvement like renal, hepatic, or neurological, hematological manifestation or presence of fetal growth restriction. So you have to rule out this severe preeclampsia also. Then another thing is posterior reversible encephalopathy syndrome and other rare neurological manifestation. So PRES or posterior reversible encephalopathy syndrome, it usually complicates the hypertensive disorders of pregnancy. The symptoms are headache, visual loss, impaired consciousness, and seizure activity. Diagnosis is routinely confirmed by MRI, where there will be presence of subcortical white matter edema, usually in the parieto-occipital area. This is a rare, PRES is a rare thing during pregnancy. Prognosis is generally favorable with underlying cause. So basically, the control of hypertension and delivery of the fetus, it usually resolves this PRES. Other causes can be venous sinus thrombosis. So increased risk of this venous sinus thrombosis, it is associated with increased maternal age, hyperemesis, preeclampsia, and cesarean section. The presentation in case of this venous sinus thrombosis will be headache, paresis, seizures, blood vision, and papilloedema. Also, this cortical malinghness or ischemic optic neuropathy, it can occur in case of severe of eclampsia. Also, in case of hyperemesis gravidarum, nutritional optic neuropathy can be observed. So, any visual symptoms, if it is developed in pregnancy, the ophthalmology referral should be done. So if you are suspecting any optic nerve function, and there should be always a visual field testing should be done. Now What are the disorders which can occur during labor? So one is the subconjunctival hemorrhage. So it is normally a benign finding, innocuous finding, which is which can be there during labor or after delivery up to 10% of patient. Also, it is seen with repeated vomiting, coughing, or eye rubbing. In non-pregnant patient, repeated episodes of the subconjunctival hemorrhage, it should exclude this hypertensive disorders and clotting screen. While in pregnancy, this is usually benign and single 1 or 2 episode, it doesn't require any investigations, only reassurance will be sufficient. And it usually resolve over a period of weeks. Then Valsalva maculopathy, it is a rare condition. It is usually superficial retinal hemorrhages, usually involving macula. The cause can be increased intrathoracic or intra-abdominal pressure during labor, and it is transmitted to eye, which can cause a sharp rise in intraocular venous pressure, which cause rupture of the superficial retinal capillaries. Here the complaints will be sudden visual bleeding, usually central following labor or any episode of straining like coughing or vomiting. Ophthalmology referral is required to confirm the diagnosis. The prognosis is variable depending upon the severity of hemorrhage. Usually, the hemorrhage will be mild and spontaneously resolve. However, in some cases, there will be dense or persistent premacular hemorrhage, and also there will be damage to the retinal epithelium. Then Posture's retinopathy. It is characterized by retinal hemorrhages, edema, and cotton wool spot. It is predominantly located around the optic disc. It can usually occur in uneventful labor or in cases of severe preeclampsia or eclampsia. The cause is unknown, but it is usually associated with microembolic occlusion of precapillary arterioles. Then rhegmatogenous retinal detachment, which is called as RRD. It is usually predisposing to secondary to a tear or hole in the retina, which is already present and which will lead to the retinal detachment from the underlying pigment epithelium. So predisposing factor is either a presence of tear or hole in the retina. Okay, so it is not related to the forcible pushing or changes in the eye pressure. So previously this RRD is known to cause, obstetrician used to believe that forceful labor or prolonged straining, it causes this RRD. But now the evidence is found out that it is not a labor or prolonged straining is responsible for RRD, but it is because of underlying tear or hole in the retina. So any previous history of retinal tears or any previous retinal surgery, it is not a prerequisite for a cesarean section. So they can safely deliver vaginally, and any straining which will not cause usually retinal detachment, okay, or cesarean section will not prevent it, okay. So they can deliver vaginally. So this is regarding the RRD. So this is basically regarding this ocular manifestations talk. Here the important part you have to remember regarding is the hypertensive and diabetic retinopathy. This is the most important thing that you should remember from this talk. So thank you for attending today. I think from tomorrow, I'm not very sure when I can conduct, but at least I think this week and next week till next Thursday, I think it will be difficult for me to conduct classes. If any time it is possible for me, I will inform you. Okay, or otherwise we will meet next week. So thank you.
Thank you,
And bye.
ma'am.
Thank
you,
ma'am.
Thank you, ma'am.
Thank you, ma'am. Thank you, ma'am. Thank you, ma'am.